Thank you very much for the introduction, and it's a great privilege to be here today, and thank you very much to the excellent organisers for putting on such an amazing event. So I'm going to talk about evidence-based care for people who have self-harmed. First of all, I'm going to talk a little bit about suicide, a bit about self-harm, and then a bit about evidence-based care, and I'm going to focus on three main areas. So risk prediction, psychosocial assessment, and then aftercare, so treatment. Then I'm going to talk a little bit about what actually happens in practice and how we might improve care for people who've self-harmed. Okay, so suicide, as people here will be well aware of, it's a globally important public health issue. There are over 700,000 people each year who take their own lives. It's a little bit more tricky to estimate the numbers of people who attempt suicide, but the World Health Organization estimates that for every person who dies by suicide, there are at least 20 others who attempt suicide. In England, if we take a 10-year period, say from 2010 to 2020, there were over 68,000 people who took their own lives. So that's an average of over 6,000 per year. We know that around a third have been in contact with mental health services, so they're patients in mental health services. And we know that self-harm is also common when people have died by suicide. So, for example, 2/3 of general population, people who die by suicides, have a history of self-harm. And if we look at younger age groups, so say, for example, women under the age of 25, 88% have a history of self-harm, and a third have sought help for self-harm the 3 months prior to their death. Now, every time we talk about numbers and we talk about statistics around suicide, we need to remember that these are people who have very tragically lost their lives. These images on the screen here are from a project that I had the great privilege of being involved in a long time ago when I started my PhD in Dublin. And it was a collaboration between art and science. The scientist was a guy called Professor Kevin Malone, and the artist was Seamus McGuinness. And they worked very closely with families who'd lost a loved one to suicide. And Seamus created these very tactile artworks. And the whole aim was to address the anonymity and stigma that you find around suicide. And it had a profound effect on me throughout my career, and I always think it's important that we remember those lived lives as well as the lost lives. Okay, so suicide prevention strategies, recent one just published for England. So locally and internationally, recognize key groups in order to kind of reduce suicide rates. So we have, for example, people who are in contact with mental health services, and we also have people who have self-harmed. And we know that self-harm is also a key issue for patient safety in healthcare services. So, for example, self-harm is the most commonly reported incident in mental health services and the one most likely to result in death. We also know that in many Western countries, the rates of self-harm are increasing. So this is a paper that was recently published by colleagues, and it looked at very recent data from primary care databases, and it looked at temporal trends in self-harm and in eating disorders. And what they found was pretty stark increases amongst young females from age 13 to 16. Okay? Now, sometimes when we talk about self-harm, people make assumptions and they think, oh, this is just an issue amongst young females. It's not. So we also know that there's rising rates of self-harm across midlife. So this is a paper that was led by my colleague, Dr. Caroline Clements. And Caroline found those rising rates of self-harm in midlife were associated with economic factors and alcohol, and that rise in rates of self-harm was linked to the rise in rates in suicide. And that's particularly important given the current context that we find ourselves in at the moment in terms of cost of living issues. Self-harm is also common amongst older adults who are also much more likely to die by suicide when they do harm themselves. Yet, despite the presence of potentially modifiable factors for intervention, only a small minority get referred to specialist mental health services. We also know that suicide and self-harm, so self-harm is strongly associated with suicide. This is a study that was led by my colleagues in the University of Oxford as part of the multi-centre monitoring study of self-harm in England. And what they demonstrated was the particularly high risk of suicide immediately after hospital presentation for self-harm. So that's that jump that you can see there. Okay, so what do we know about evidence-based care? We've seen what an important issue suicide is and self-harm. So what can we do? But let's look at the prediction of risk, okay? So this is predicting who might be at further harm. Just to give a little bit of context around risk scales and tools in England and globally, there's a lot of the guidelines said different things. So some guidelines said, don't use them, and then other guidelines said, well, as long as they're psychometrically tested and reliable and valid, then, you could use them. So we did a very large program of work, which is still ongoing, where we looked at what scales and tools were in use and also the predictive performance of those scales for repeat self-harm and for suicide. And I'm going to touch on some of this work here this morning. Okay, so we looked at the different scales and tools that are in use, and I'm going to focus on the middle paper here, which is a report by the National Confidential Inquiry into Suicide and Safety in Mental Health Services. So they looked across all the mental health services in the UK, and they asked people for what risk tools that they were using. And they found that there was 156 different tools and scales in use in the United Kingdom, which really gives an indication of the lack of consensus over kind of which scale is best to use. So we looked at that, and we looked at the predictive performance of different scales in a systematic review, and then we got those best performing scales and the ones that were most widely used, and we tested them in a prospective cohort study. Okay. So we had the risk assessment tools, and we had them as part of the regular assessment. We had 5 sites. We recruited around 483 people, and then we tested the performance of the scales. What are the scales? So these are examples of some of the best performing ones. We had the Manchester Self-Harm Rule and the REACT Rule. So you can see kind of clinical items, recent self-harm, current psychiatric treatment. Then we had the modified sad person scale. So this is a scale that was developed as a training tool, and then it started to become widely adopted across mental health services for predicting who would be at risk or who should get what treatment. Then we have the Barrett Impulsivity Scale, which is it's kind of used a lot in the States, and it's a trait and state measure of impulsivity. And then we had these global scales. So this was simply asking the clinician or the patient what was their estimation of risk of repeat self-harm in the next 6 months. So we used a number of different diagnostic accuracy statistics to evaluate the performance of the scales. And some of these might be familiar to people. So we had things like sensitivity. So I'll just touch on a few of them. That's the proportion of those who go on to repeat self-harm who've been identified at high risk by the test. And possibly one of the most important for clinical practice is positive predictive values. So that's the probability that the person actually identified at high risk actually goes on to repeat self-harm. And then we have area under the curve. So this is a measure of global discrimination. So we can compare different tests. And the closer it is to the upper left-hand corner here, the better it is the test is at discriminating. And the closer it is to line A, it means that it's kind of no better than chance. So what did we find then? So we found a lot of the tested scales that we looked at had high sensitivity but low specificity, and vice versa. But when we looked at the global performance, so the ability of the scales to discriminate between cases and kind of controls, we found that none of the tested scales outperformed simply asking the clinician or the patient for their estimation of risk. But that wasn't good enough to be used in routine practice either. So when you're conducting real-world research, it can be challenging. There's always the potential of bias around recruitment. So to counteract that, we also conducted a population-level study where we got the scale items from healthcare records, and we tested the performance of the scales there for repeat self-harm and for suicide. And we were also able to look at, was there a difference in who did the test and in the gender of the person? So what did we find? Well, we found the performance still was pretty poor, still did not outperform simply asking the clinician for their estimation of risk. And when we looked at the prediction of suicide, the positive predictive value, so that's the probability that the person identified at higher risk actually goes on to die by suicide, was less than 1%. So that means they were wrong 99% of the times. Okay. But, they're widely used. We saw there was over 150 different tools and scales in use. So maybe it's because they're cost effective. Well, we also looked at that. And we had our health economist colleagues construct a Markov model, and we found that none of the scales were cost effective compared to clinical judgment. And as I said, that's not good enough to be used in routine practice either, because it results in incorrect allocation of costs and treatment opportunities. So what can we do then? Okay, well, we can focus on conducting good quality psychosocial assessments. So psychosocial assessments, they're hopefully a collaborative interview between a clinician and a patient, where the clinician will hopefully evaluate those individual needs, risk, and look at the reasons why somebody is self-harmed. We do have evidence for the benefits of good quality psychosocial assessment for helping to prevent repeat self-harm, and they're also cost effective, so they're good for the system and they're good for the patient, and they're recommended by clinical guidelines for quite some time now. We also have evidence for prompt access to aftercare and psychological therapies. So we know that they're effective in helping to prevent repeat self-harm, and that engaging in aftercare and psychological therapies can help prevent suicide and further adverse outcomes. A lot of the evidence centers around cognitive behavior type treatments. That's not to say other treatments aren't beneficial, but the evidence is really centered around CBT type treatments. Then timing matters. So when people have harmed themselves, they tend to repeat self-harm quite quickly. So the timing of those interventions matters. If we want to prevent further harm, we need to provide those interventions quickly. But what actually happens in practice is a little bit different, and I'm going to go through some of that now. So let's look at psychosocial assessments first. So this slide here is from a study that was conducted by Dr. Jane Cooper on our centre. And Jane looked at services for self-harm in a randomised sample of 32 hospitals in England. And what she found was a really variable rate of psychosocial assessments. So some hospitals were better than others. They were given 90% of people who came to hospital received an assessment. Some were much worse, only 22% received an assessment. And we know from a lot of quantitative studies now that the average rate of psychosocial assessment is only about 50 to 60%. So that's a lot of people who come into hospital who don't receive evidence-based care. And we wanted to understand why, what was happening. And I'm going to talk about some of the patient work now. So when we asked patients, what's happening when you come to hospital? Why are you not receiving an assessment? Their responses fell into three broad areas. So we had patient reasons for refusing or leaving before an assessment took place. And then we had these organisational circumstances. So some of the patient reasons included being in a very noisy and busy emergency department, or having stigmatising responses from healthcare practitioners, or it just not being the right time to talk, or having to be somewhere else. Gateway issues is where the person might have wanted an assessment, but they didn't get through the gateway to access the liaison team, so the mental health team. And that could be because they didn't receive medical treatment because they'd harmed themselves, or because breathalyzer tests were being used to exclude people, or these nuanced issues over communication and capacity. So having an assessment depended on how the person communicated their self-harm. So for example, maybe if a person was autistic, they might communicate their distress differently, and the person was just assumed that they didn't want an assessment. And then we had these threshold issues. So this is where the assessment depended on this kind of evaluation of risk, usually centered around assumptions around methods of self-harm. So for example, self-injury or self-cutting, contrary to evidence now, deemed less serious and the person less likely to have an assessment. What about the people who did receive an assessment there? What happens there? So we find that people receive very variable and often poor quality care, very long waiting times, noisy, busy emergency department, and stigmatizing attitudes, and we've seen people leaving the emergency department for those reasons. But then also coercion and control, so this is where security guards can be used for monitoring. Assessments that are overly tick box, and the questions are intense and invasive, and people just have to repeat information over and over again, even though it could be kind of looked up on notes. So what about access to aftercare and interventions then? Okay, back to the 32 hospital study led by Jane Cooper. What we're looking at here is the rates of referral to any mental health service, and it's lower and more variable. So we have the median here is around 28%, so only a third of people presenting to hospital with self-harm receive a referral to any mental health follow-up. If this was just outpatient appointments, that would be much lower. So this includes referrals to voluntary sector organisations. What's the situation like in primary care? I'm afraid it's not much better. So this is a paper that was led by my colleagues, and they looked at self-harm presentations to primary care. Medication was first-line treatment, despite some of the do-not-do guidance around tricyclic antidepressants. Only a minority were referred to specialist mental health services, and there was indications of the inverse care law, so people from more deprived areas were less likely to receive a referral to mental health services. What about patient and staff views? So we wanted to understand from their perspective what was happening when you tried to access evidence-based care, so when you tried to access psychological therapies. All of this work is being published. If anybody wants copies of the papers, please do contact me. So patient experiences. It's really difficult to ask for help, and when people finally manage to do that, then they're being met by failed promises and uncertainty, long waiting times, a lack of tailored interventions, and stigma. They can be challenging to access, irrespective of the pathway. So, for example, the self-refer route can be really hard when you're not feeling well, and then it's just hard anyway, and then also going through clinicians might mean that you get bounced across different services. Ultimately then, in a lot of cases, there's no place for self-harm. So you're told you can't access a treatment if you have self-harmed. You're excluded from other treatments if you self-harm during the treatment. Then ultimately, there's a lot of people who are left struggling alone because of difficulties in accessing aftercare. We asked staff about what was happening when you tried to refer people into aftercare. And again, they talked a lot about IAPT and exclusion, risk and thresholds. So people being told that they're too high risk for primary care psychological therapies, but then not high risk enough for secondary care therapies. And there was also this perception of self-harm as a social crisis, therefore not under the remit of secondary care services, which were for people with serious mental illness. There's a lot of focus on preventing inpatient admission, repeated assessments leading to bureaucracy, strain and delays, long waiting times for the person when they're in the emergency department and trying to access services. And a lot of this leading to a lot of despair for the person who can't access the help that they need, but also for the clinician as well, who wants to provide prompt aftercare, but the services just aren't available. So what can we do then to try and improve care quality? We've seen that really needs to happen. Well, we have the NICE guidelines, and these were recently published last year in September. And we have the quality statements. So these are a set of standards that we would expect good quality services to have when they're caring for people who have self-harmed. Originally published in 2013 and revised recently. And the first statement there, I'll read it out, and it says, people who have self-harmed are cared for with compassion and the same respect and dignity as any service user. So we've been saying this now for a long time, and it's like the foundation block of trying to provide good quality care for people. The NICE guidelines come on very strong and very clear now about the use of risk assessment tools and scales. Do not use risk assessment tools and scales to predict who's going to self-harm or die by suicide. Do not use them to determine who should get what treatment or who should be discharged. Do not use stratification, so low, medium, and high risk for any of those areas. Focus on providing a good quality assessment. The NICE guidelines also has some recent updates on the provision of aftercare. So it emphasizes again the importance of psychosocial assessments, like we've been saying for a long time, but as part of the assessment that the clinician should discuss and agree and record the aftercare plan, and that prompt aftercare should be provided within 48 hours of the presentation. In the NICE guidelines it said where there is a safety concern, but ultimately anybody who's presenting to healthcare services with self-harm, it is a safety concern. The NICE guidelines also emphasize the importance of continuity of care. So that initial aftercare is provided by the same team who carried out the assessment. So that might be the liaison team in hospital, or else it might be in primary care. And presentations to primary care that the GP maintains regular contact and follow-up. And then any conditions or any interventions are planned according to coexisting conditions. So what we find is that there's a lot of beneficial evidence-based treatments for coexisting conditions, but people get excluded from them because of self-harm, which goes against clinical guidelines. And then to consider the use of safety plans. So what about patient and staff views? Well, when patients talk about what can we do to improve care, these results are consistent with a lot of lived experience testimony and a lot of research. So humanizing care, collaborative assessments, actually having space and time to talk, compassion and reassurance, and then actually receiving help. Then what about that help? What do patients say about that? Well, again, the importance of compassionate and informed staff, but then actually having well-resourced services available. And then having information, so having information, what treatments are available, what's the benefits of one treatment over another treatment, how do I access them, will it help me? Interventions that are tailored, and then having choice. So group treatments might be good for some people, they might be awful for another person who might prefer individual interventions. And then having timely access, so not those really long waiting times that we see. And then having interventions that are accessible and flexible, instead of people being dropped from their treatments because they can't attend an appointment, because it's really far away, or because they have to work and they can't make to the appointment. And then consistent with the NICE guidelines, that continuity of care. What about staff? So we asked staff, what actually helps open those barriers to get people the care they need? And they talked about the importance of really close-knit, skilled teams and actually having the time to provide therapeutic assessments, then crafting and tailoring referral letters to the service. And this is where people like clinical psychologists were valuable because they had an in-depth kind of awareness of relational factors and referral criteria and the availability of different kind of interventions. Then probing boundaries and advocating for patients. So doing anything possible to kind of challenge assumptions around self-harm and do whatever people could do to advocate for the person's needs. And if personality clashes happened, to escalate it up, involved senior staff, anything that could happen to get the best possible outcome for that person. They also talked about the importance of relationships. So building relationships within teams and across teams, and having services that were open, accessible, and integrated. There was a small number of hospitals, so this is from a 32 hospital study that we did, that had an outpatient clinic as part of the service, but most people didn't. And most people wanted to have some sort of follow-up service to address that gap, that really, really serious gap that happens in services for when somebody presents to hospital and they can't access primary care and they can't access secondary care. And we know the risk of suicide is high immediately after hospital presentation for self-harm. So how can we go further? How can we translate evidence to practice? Because we've seen there's a lot of gaps there in clinical practice between policy, evidence, and practice. At the University of Manchester, we do a huge amount of patient and staff involvement. So all of our studies are co-designed from the start right through to implementation. This is some of our patient advisors. So everybody has personal experience of self-harm and attending mental health services. And we have a very large group of people that work with us, and they've been working with us for quite some time now. And they've been involved in a huge amount of studies and grant applications. We also work with staff. So we work with staff very closely all around the UK, really, in lots of different services. And part of the work that we also do is we engage with policy and practice. It's not enough, and we've seen the gaps in services. You can publish as many papers as you want, but that doesn't mean that they're going to actually make a difference in clinical practice. And we've seen that a lot of it doesn't. So the change that needs to happen is interacting with services and patients and policy. As an example of this, we've worked with NHS England on a very large programme where we worked with 42 integrated care systems to try and support services to improve their offers for people who have self-harmed. And the programme was nested within the NHS long-term plan and community mental health framework. And we did a lot of engagement and support with services where we helped people develop plans that were evidence-based and also around co-designing plans and patient involvement. Then we had a lot of engagement where we went into services and we talked about evidence in a very accessible way. And then we had a lot of specialist kind of sessions on particular issues around equality and diversity. So, for example, LGBTQ+. And the whole programme of work was attended by a lot of services, and it's still ongoing now at the moment. What else do we do at the Patient Safety Research Collaboration? Well, we're continuing our research that I'm very proud to be a part of, actually, because it's very applied and translational. And it's focused on what actually happens in services. So we're right in the middle of where it happens. And we're trying to progress the interventions and the access to aftercare because we know that's desperately needed at the moment. So we focus on 3 areas. We have specialist mental health services, and we have self-harm services, so that's around, say, liaison psychiatry services, but other interventions that have been developed. And then primary care. Primary care is a huge, huge area in need of improving and developing services. So I've spent a lot of time working in liaison psychiatry. Now, primary care is even more in desperate need of access to aftercare. The way we're looking at interventions is trying to combine research skills and research experience with what is happening in services. So interventions that are driven by the needs of the population in that area. So we're trying to find interventions that are happening in practice that show promise, trying to understand what's working about it, what can we learn from it, and can this be translated and implemented elsewhere, so we can remove things like postcode lotteries and broaden that access for all people who have self-harmed to ensure they get the care that they need. Okay, so thank you. I'm not too sure how I'm doing on time, but am I okay? Okay, so people who have self-harmed, we know they're at high risk of repetition, really important group in and of themselves, but also at significant risk of suicide. We also know that there is substantial variability and unmet need when people do try to access help after they have harmed themselves. We've seen the evidence now and guidelines for risk prediction. So to sum that up, do not do. Okay? And then what the evidence does suggest is providing good quality psychosocial assessments, prompt access to aftercare and psychological therapies, continuity of care, and tailored interventions. That's not enough, though. We need to focus on translating research to practice to make sure that we improve care quality. And we think that that is important, and that it's important to engage with patients, policy, and practice. Okay, thank you very much for listening today, and just to thank the team in Manchester, the University of Manchester.
Thank you very much.
I'm a bit early.
Thank you very much, Leah. Maybe just in case there's any questions. Thank you. So, thank you very much for a really detailed talk, taking us through a significant body of research, the diversity of patient presentations, how they navigate a really complex system that we have, and then for those that are lucky, I think, reaching a tailored intervention. So I think it's very complex. So thank you very much for taking us through that.
Okay.
So we have some time for questions. Does anyone have any questions, please? Yes. Is there a mic, actually? Yes. Over to James. Thank you.
Thanks for that, Leah. That was a really good presentation and really informative. It's great to see the way you're, particularly towards the end, you were talking about taking your work out into these 40-odd different health services and so on. I just wondered, my sort of thought when I was looking at that and looking at the stuff that you put on, very much like this room, we'll all have been nodding along as you were talking. What's your experience with that in terms of, you obviously, I would imagine, get the people who are keen, who are thinking that way, who have that empathy and concern and know the NICE guidelines and so on. Are you hopeful to move beyond that stigma, which I think for self-harm has a huge impact on the people that present and has a huge impact in terms of stopping people presenting?
I'm always hopeful. So I'm always hopeful. It's kind of one of the main drivers in the work that I do. And I have seen change happen. And mainly that change is driven by involving people with personal experience in studies and also in health services interventions as part of peer support programs of people working in hospitals. We still have a long way to go, but I think that's why engagement is so important, and because that's where attitudes do change, and you have to keep pushing forward with it. And I think the involvement of people with lived experience has done a huge amount to challenge those attitudes. So yeah, it's the core driver of my work, so I'd be in trouble if I wasn't hopeful. I'd struggle to get out of bed in the morning, I think.
Thank you so much. I really enjoyed that presentation. It hits hard, doesn't it, when you listen to those statistics? I'm really interested to know, if you don't mind, about the logistics of this sort of co-creation of knowledge that approach that you took. So how you recruited those individuals to those working groups, what the uptake was like?
Yeah, sure. We have a very large group in the Centre for Mental Health and Safety. And when we set it up, our aim was to set up something that had a more kind of permanent residency for research, rather than kind of a one-shot kind of what you see a lot as people being involved in one project. And then you have a lot of wasted expertise. So we wanted to set up something so it could be established where we could invest in people, train people, and then they could be involved in lots of different projects. So when we were recruiting people, that was kind of the outset aim, which meant people were more likely to kind of get involved. Then we have a very personal approach where we build up relationships with all of our members who are involved in our studies. And that's critical. That's like absolutely vital to do that. We have when you do all the foundation things and when you recruit people, if you treat people really well, if you invest in training and you invest in relationships and opportunities, pay is really, really important. I get really annoyed at when involvement activities happen and people don't get paid. So there are a lot of standards that are out now around involvement and co-production. We pay according to the NIHR standards, which are minimum £25 per hour. And if anybody wants any details on that, we've actually drafted a kind of a guideline. Well, it's not a guideline, it's kind of based on our learning tips and strategies that have helped us. And our group, so one of the advantages about having a very large group is because people become unwell, and they can become unwell and that can fluctuate. And if you have a large group, then we can do a lot of different things. So we can make sure projects are delivered on time, but then also we can have a really open door policy. So we can say if people become unwell, it's okay, it's fine, don't worry about it. The work will still be here, take as much time as you want and you can come back. And that's worked really well with people. We've never had, our group are so large, and because of all of these things that have worked well, we've never had a problem. And I find it strange when people, if you do things well, there's a huge amount of people who want to help. There really is. There's a lot of people who want to get involved in different projects. Linking into support is really important. So there's a lot of assumptions around self-harm and suicide that if you talk about it, you're going to make people more unwell. They might go off and harm themselves. It's not, doing involvement work is hard, right? And even though you're focused on research, people still disclose a lot of personal issues, and it can be really tiring for people, and they can become upset. But from a research perspective, it doesn't last, and people often feel better as a result of the process. And I've seen people utterly transform as a result of being involved in research, where people have been involved in lots of different papers and grant applications. They've gone on to do lots of different things. So there's an awful lot of benefits to it. But you still have to consider well-being as a foundation for everything. And we co-designed well-being plans with our members, so our members could complete well-being plans. And I'm happy to share anything. We have our tips and strategies written up in a document. We've co-designed well-being plans. I'm happy to do anything to improve co-production in any sort of research or intervention development. So please do contact me if you want anything or better information. I'm always happy to help.
Oh, one more.
Hi. Thank you for the talk. It was very extensive and interesting. I've seen last year the change of the NICE guideline as well, and has been amazing. And I think some of your research, as I can see, had informed the NICE guideline. So what I wanted to ask was, when you show a picture of people that were helping, so there was a, that you say that basically they were, had experience of self-harm, or are those the people you are talking about just now, minutes ago, or were those people, because was a small group of people?
No.
No, okay.
No, so this is like a culmination of a lot of different studies up here. So the co-production group, one of the things that's quite important to understand is there's a lot of confusion over co-production and involving people with lived experience in research and having people with personal experience as participants. Okay. So co-production, when we're doing co-production, people are using their personal experience to inform research and to make that research better and to make it more meaningful. As participants, they're sharing their personal experiences so we can use that data to analyze it and to inform clinical practice improvement. So the studies that I talked about today were from participants. And one of the studies, it was qualitative, but it was over 150 people who had attended healthcare services for self-harm. So, and we've done a lot of different studies, but that was a qualitative study, but still quite large numbers.
Okay. So the group that you put on the picture is a group of people that work with you?
Yes.
Okay.
So that's the co-product, that's some of our members of the co-production group. Yeah.
Okay, perfect. Thank you.
Yeah.
Hi, thank you for the talk. It was very interesting. I was really interested in the tailored interventions. So it was like, are there core elements in every intervention? Or is there a lot of variability in these interventions when they're tailored for different groups?
Well, that's a really good question. And so the evidence is around CBT type interventions. But a lot of those interventions aren't tailored for people who have self-harmed. So there's a bit of difficulty there. And then there's a lot of comorbidity of different conditions as well. So people are struggling to often find interventions that suit them. And particularly a lot of the treatments that people are offered, they may not be that suitable for their particular issues. So for example, somebody with a lot of difficulties and maybe struggling with self-harm, they've been offered 12 sessions of cognitive behavior type treatment may not be that effective. So tailored treatments that address their particular needs and context would be important. But we find that, unfortunately, there's a lack of them. There are some, and that's what we're trying to kind of find and trying to improve access for people, you know.
Thank you. My question sort of relates to the last one a bit, actually. I'm autistic, and there's quite a bit of evidence that CBT isn't that effective for autistic individuals. And that can be a real barrier because the NHS has invested so heavily in CBT, trying to get any other therapy. So do you have any comments around that, sort of other therapies that can be offered to autistic individuals that have better success? Yeah,
so that is very similar to the main issue around the lack of tailored interventions there. Personal disclosure, so like I'm also autistic, so is my daughter. And I've seen the harm that happens when people receive treatments that are inappropriate. So when my daughter has received CBT type intervention and she got worse. So it is quite infuriating, really, you know, the kind of the provision of treatments that don't consider those individual needs. I am not as familiar with the interventions on a research level for autistic individuals. It lags behind hugely compared to other research. Some of it I find quite upsetting, so I kind of avoid it. There is good research happening on the provision of safety plans for autistic individuals, and that research it's been led in Nottingham, and it's a very co-designed research area. So that's on the provision of safety plans for autistic individuals. And we have a talk on our website by a stellar researcher called Emma Nielsen, who talks about the safety plans. And I can send you the link to that. It's really, really, really good. And there's Sarah Cassidy in Nottingham. Yeah, so she does a lot of research in this area, and she does a lot of research around suicidal ideation and suicidal behavior and self-harm. That's the main good quality research that I see. A lot of research, as you will know, is focused on children and adolescents. And then also we have a kind of a blind spot for women.
Yeah, I'm part of a co-production team of autistic individuals involved in research now and education of NHS professionals.
Great.
So, yeah, it's a program that's just getting up and running by AT Autism and Anna Freud Centre. So yeah, I totally agree with you that co-production is so important.
Yeah, definitely.
Final one just at the back, in the middle. Yep.
Thank you very much. So my question links to the previous first, the first and the last ones. Do you have any additional provisions for veterinarians or more in general healthcare professionals that seek care? And there might be additional barriers for them to do so when they're supposed to provide care. So is this anything that is known, if there are additional barriers for them?
It's a really good point, and it's part of the reason why I'm here today. So I can have better knowledge about what is happening in this context and what services are available and what are the issues for people in the veterinary professionals when they try to access care. So I'm afraid you've got a lot of better experts in the room than me when it comes to talking about those issues. And we have Rosie here as well. So I'm here to learn about that.